So I hope you enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome.
Hello, I'm Dr. Kevin Teal, MD. I'm a neurosurgeon, and today we're going to be looking at the pharmacology of epilepsy. By way of introduction, epilepsy affects approximately 3% of people by the time they reach 80 years of age. Approximately 10% of people have at least one seizure in their lifetime. Epilepsy is the third most common neurologic disorder worldwide after strokes and Alzheimer's. Single drug therapy allows control in 80% of patients who have epilepsy. Again, when we look at those who are treated for epilepsy, roughly 1 in 10 patients can have medically refractory epilepsy. When we discuss epilepsy as a disease, it is a chronic disorder that is characterized by recurrent seizures. These seizures are episodes of brain dysfunction due to abnormal discharge of cerebral neurons. When we look at the site of the abnormal brain electrical firing, this will determine the symptoms, including loss of consciousness, abnormal movements, atypical or odd behavior, or distorted perceptions. Epilepsy generally is divided into idiopathic or symptomatic. When we approach idiopathic epilepsy, this describes the most common form of epilepsy in which no anatomic cause for the seizures is found. There is no clear trauma or tumor. This is also called cryptogenic or primary epilepsy. This is possibly due to an inherited brain abnormality, and it does require chronic treatment with anti-seizure drugs or, in some cases, a vagal nerve stimulation surgery. Turning to symptomatic epilepsy, this is an epilepsy that can be traced to a source that causes 2 or more seizures. It is also called secondary epilepsy. The causes include illicit drug use, head injury, meningeal infection, tumors, hypoglycemia, or alcohol withdrawal. Chronic treatment may not be needed if the cause of this seizure can be identified and corrected quickly. Turning toward epilepsy in children, or seizures in children, the most common causes are genetic, infection, trauma, congenital abnormalities, or metabolic dysfunction. Classifying seizures is important in the process of management. This will determine the appropriate treatment options. The seizures, again, are categorized into partial or generalized groups by the site of origin, the etiology, the electrophysiologic features, and the clinical presentation. Working through the classification of seizures in terms of their origin, we discuss partial seizures and generalized seizures. Partial seizures are notable because the consciousness is usually preserved during the seizure. These seizures involve only a part of the brain, usually one lobe of one hemisphere. They may progress to generalized tonic-clonic seizures, however. Turning to the generalized seizures, consciousness is usually lost immediately and there is no memory for the seizure. These may begin locally, then produce bilateral brain hemisphere abnormal electrical discharges. Primary generalized seizures may be convulsive or non-convulsive. In addressing partial seizures, the symptoms of each seizure depend on the site of neuronal discharge and the extent of spread to other neurons. Partial seizures are classified as simple, complex, or secondarily generalized. These seizures can cause status epilepticus, which is associated with the loss of consciousness and memory. In the pharmacologic treatment, the options include lamotrigine, levetiracetam, and topiramate, some of the newer antiepileptics. Again, with simple partial seizures, these are due to a group of hyperactive neurons which show abnormal electrical activity in a single area of the brain without spread. The patient does not lose consciousness and can describe the attack. We usually will see abnormal activity of a single limb or muscle group that is controlled by the affected brain area, and these seizures last 60 to 90 seconds. The patient may have sensory distortions that spread, and these seizures may occur at any age. As we look at the complex partial seizures, these generally last 30 to 120 seconds. The patient gradually recovers consciousness with possible ill or tired feeling that may last for several hours after the attack. Again, this would be referred to as a post-ictal state in this patient. These complex partial seizures can occur at any age, and again, the pharmacologic treatment options include lamotrigine, levetiracetam, and topiramate, again, the newer antiepileptics. Again, complex partial seizures are localized discharges, and their onset and spread usually will involve the limbic system. These are characterized, the complex partial seizures, by complex sensory hallucinations, mental distortions, loss or altered consciousness, and automatic motor movements called automatisms. As we look at these automatisms, they may include chewing movements, lip smacking, swallowing, fumbling, scratching, and even walking. Again, in the motor arena, we can see diarrhea or urination as they have some loss of smooth motor control. These seizures may be part of a continuum of progression from a partial to a fully generalized seizure. The generalized seizures may begin locally, again, but they cause abnormal electrical discharges throughout the cerebral hemispheres rapidly. These may be convulsive or non-convulsive. Again, they are usually associated with an immediate loss of consciousness. As we look at the types of generalized seizures, there's the classic tonic-clonic, absence seizures, there are myoclonic seizures, febrile seizures, and status epilepticus. There are other seizure syndromes, atonic seizures, and infantile spasms. As we look closer at tonic-clonic or grand mal seizures, these result in a loss of consciousness that is followed by phases of a tonic or continuous contraction or rigidity that lasts for 15 to 30 seconds, and clonic, which are rapid contraction and relaxation movements, more characteristically the jerking that we see bilaterally. These may be followed by a period of confusion, exhaustion, or stupor as the patient goes into a post-ictal state due to a depletion of glucose and energy stores. Again, the pharmacologic treatment options include lamotrigine, levetiracetam, and topiramate. As we look at the absence seizures, these are brief, abrupt, and self-limiting, and they cause a loss of consciousness. The onset is usually in patients at the age of 3 to 5 years, and these seizures can last until puberty or later. The absence seizures are associated with staring spells and rapid eye blinking that can last for 3 to 5 seconds. An EEG will show a distinct 3 per second spike and wave discharge pattern. The pharmacologic treatment options include divalproex, lamotrigine, and ethosuximide, with the last one being the preferred medication. Looking at myoclonic seizures, these consist of short episodes of muscle contractions that may reoccur for several minutes. They often occur when the patient first wakes up and are noticed as a brief jerking of the limbs. Again, myoclonic seizures may occur at any age, but usually begin around puberty or in early adulthood. This myoclonic jerking pattern may be seen in other seizure types. The pharmacologic treatment includes divalproex and levetiracetam. Looking at the subject of febrile seizures, these normally are seen in young children with an illness that is associated with a high fever. These may occur in siblings. They are generalized short-duration tonic-clonic convulsions. They are not clearly indicative of epilepsy or recurrent seizures being seen. Their treatment includes corticotropin, or ACTH, and vigabatrin. The syndrome that is most concerning with generalized seizures is a syndrome called status epilepticus. This is when the patient has 2 or more seizures and they occur without recovery of full consciousness between them, or the patient has a seizure that lasts greater than 20 minutes. These may be partial with secondary generalization or primary generalized seizures that are convulsive or non-convulsive. This generally is a life-threatening emergency that may require emergency treatment including respiratory support and ICU observation. The treatment begins with intravenous diazepam or lorazepam, and then this is followed by IV fosphenytoin. There also may be an option to use IV levetiracetam. When we look at the mechanism of action of the anti-epileptic drugs or the anti-seizure medications, there are 3 drugs that block sodium channels. These are carbamazepine, fosphenytoin, and oxcarbazine. There is 1 drug that blocks calcium channels, and this is ethosuximide. There are two drugs that work at the GABA receptor. This is primidone and tigabine. There are 7 drugs that have multiple mechanisms of action. These are divalproex, felbamate, lamotrigine, levetiracetam, pregabalin, topiramate, and zonisamide. As we look at the choice of drugs, this is going to be based on the seizure type and some patient-specific variables, such as their age, any kind of medical comorbidities they may have, such as liver function abnormalities, their lifestyle, and drug traits such as interaction with other medications that the patient may be taking and the cost of the drugs.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Calm down, dude. I'm coming. Sup?
Well, now that we are all here, what drugs are famous for inducing cytochrome P450?
I don't know, Hal. However, will I remember?
Just think. BCGPQRS, barbiturates, carbamazepine, griseofulvin, phenytoin, quinidine, rivampin, and St. John's wort. BCGPQRS.
Really? No witty word or phrase? Just BCGPQRS.
Yeah. BCGPQRS.
You're not even trying anymore.
What? Oh, seriously?
Hi, I'm Dr. Chris Lewis. This is your first quick review for your anti-seizure drug lecture. Let's get started. What is the treatment of choice for controlling a single febrile seizure? Well, this is a bit of a trick question. We've been talking about seizure drugs, but the answer is not a seizure drug. Actually, it's just control the fever. Febrile seizures don't necessarily indicate an increased risk of epilepsy in the future. So when you see a patient in the emergency room, a young child usually, and they've come in with a high fever and they've just had a seizure, most of the time it's just reassuring the parents. Make sure the fever gets down, treating the infection that is causing the fever, and then some close follow-up afterwards. But these patients don't necessarily need to be admitted to the hospital for workup. Next, match the symptoms with the seizure type. So the first one, convulsive or non-convulsive seizures with immediate loss of consciousness. Well, that's going to be your generalized seizure type. Abnormal activity of a single limb or muscle group, that's going to be your simple partial seizures. And then automatisms, mental distortion and loss of consciousness. Sometimes you can also see hallucinations, or patients will answer incorrectly to questions posed to them, and that's going to be your complex partial seizures. Moving on, what are the signs and symptoms of an absence seizure? Well, you get a brief, abrupt, self-limiting loss of consciousness. Usually, the age of onset is 3 to 5 years. They usually last until puberty. And the patient will stare and will exhibit some rapid eye blinking. And this usually goes on for about 3 to 5 seconds. And it has a very distinct 3 per second spike and wave discharge seen on an EEG or electroencephalogram. Next, what type of seizure is most associated with lip smacking or chewing movements? That's going to be your complex partial seizures. And then next, describe the post-ictal state. Well, this is confusion and drowsiness after the seizure. The duration is somewhere between 5 and 30 minutes, but for very severe seizures, it can last for hours, and patients will be very sleepy. So they will sleep off a post-ictal state quite often. And then amnesia. They're not going to remember that they had their seizure. So one, they're kind of drowsy, they're sleeping, they're waking up, but they're confused, they're not answering questions very well. And then you ask them what happened, and they'll go, I don't know. And that's the end of your first quick review. Let's get back to your main lecture.
If we look at the anti-epileptic drugs, there are what we call the primary anti-epileptic drugs. There are the older drugs and then the newer drugs. In the older drug category, we have phenobarbital, phenytoin, carbamazepine, ethosuximide, divalproex, valproic acid, and the benzodiazepines. The newer drugs include gabapentin, lamotrigine, topiramate, levetiracetam, oxcarbazepine, and zonisamide. Looking at the benzodiazepines, their action is that they bind to the GABA inhibitory receptors to reduce the neuronal firing rate. Their therapeutic use, they are adjunct therapy for myoclonic seizures or for partial and generalized tonic-clonic status epilepticus. Diazepam and lorazepam are the ones that are used most often for epilepsy management. Lorazepam stays in the brain the longest, and diazepam is available in a rectal form. These are the frontline medications that are used in status epilepticus because they can be given IV and they have a rapid response time. The adverse effects from these medications are drowsiness, sedation, and ataxia. These medications generally are not used frontline for seizure management long term. As we look at the benzodiazepines, they have advantages over barbiturates, which are one of the older drugs. The first advantage is you have fewer drug interactions with benzodiazepines. The next is you have less dangerous withdrawal syndrome with the benzodiazepines. There is a lower risk of a fatal respiratory depression. These benzodiazepines have a broader therapeutic index, and they also have a lower risk for dependence compared to barbiturates. Turning to phenytoin or Dilantin and phosphenotoin or Cerebrex, generally these medications actions are phenytoin driven, and phenytoin blocks voltage-gated sodium channels by selectively binding to them in the inactive state, which slows their rate of recovery. At very high concentrations, the phenytoin can block voltage-dependent calcium channels, interfering with the release of monoaminergic neurotransmitters, which are stimulatory. The uses of these medications include partial seizures, generalized tonic-clonic seizures, as well as status epilepticus once the control has been obtained with the benzodiazepines. Again, continuing with phenytoin and phosphenotoin, the adverse effects from these medications include nystagmus, gingival hyperplasia, ataxia, and peripheral neuropathies. The contraindications to the use of these medications: one must be cautious with these drugs because if you use them in context with other drugs that are metabolized by the cytochrome P450 system or the UGT enzyme systems, then you can have problems with either changing levels or toxic levels. Again, one other contraindication is that there is an osteoporosis risk in older patients with the use of phenytoin and phosphenotoin. Phosphenotoin is a newer form of phenytoin and can be given IV or IM. It is a prodrug that is rapidly converted to phenytoin in the blood, and it can give high levels within minutes with a lower toxicity profile. Turning to the toxic side effects of phenytoin, again, we mentioned gingival hyperplasia. There's also a concern for hirsutism. There is a concern for fetal hydantoin syndrome, which resembles fetal alcohol syndrome for fetuses that are exposed to Dilantin by their pregnant mothers. Phenytoin can also prevent the liver production of vitamin K-dependent clotting factors in utero, which is also a concern for pregnant mothers. Phenytoin can also cause a drug-induced lupus. Phenytoin has been associated with a very severe syndrome called Stevens-Johnson syndrome, which begins as a rash but can progress to liver involvement and significant systemic problems. And as mentioned before, phenytoin does induce the cytochrome P450 pathway of metabolism and can change the levels of other medications that the patient may be on. Again, when we look at phenytoin metabolism, there is a concept of first order elimination, and then there's a concept of zero order kinetics. Looking at the first order elimination, this is seen when doses of phenytoin are given and the blood level is below or within the therapeutic range. What the first order elimination means is that there will be a constant fraction of the drug eliminated with each passing half-life. This is a condition in which the medication can be titrated up safely without significant swings in the level that the patient will have in their bloodstream. The zero-order kinetics with phenytoin metabolism kick in when the drug level in the blood is above the therapeutic range. And this is a situation in which the level needs to be titrated very carefully to avoid the patient having toxicity. What this zero-order kinetics means in terms of metabolism is that there will be a constant amount of the drug eliminated per unit of time, so overall the elimination is slower. And again, the patient is more likely to have toxicity with small dose increases when their blood level is in the therapeutic or above the therapeutic range. When we look at the next medication, carbamazepine or Tegretol, the action of this medication is that it blocks the sodium plus channels to reduce the propagation of abnormal impulses in the brain. It inhibits the generation of repetitive action potentials in an epileptic focus and stops the spreading of the brain discharge. Its clinical uses have been for partial seizures, secondary generalized tonic-clonic seizures, and also it has a use for trigeminal neuralgia for patients who have facial pain. Looking at the side effects of carbamazepine, it has, number one, hyponatremia, which can be a problem in elderly patients, and it also has a concern for blood dyscrasias, so the patient's blood count does need to be checked periodically during their treatment with Tegretol or carbamazepine. The contraindications to the use of carbamazepine are that it may increase the absence seizure frequency. Again, there's some concern for use of it in patients who are older, given the hyponatremia concern. And again, because it does have some metabolism through the cytochrome P450 system, there is some concern that it can change the metabolism of other medications the patient may be on through the cytochrome P450 system and also the UGT metabolism system. The next medication we'll look at is oxcarbazepine, which is also called Trileptal. This medication, by action, is a prodrug that is rapidly reduced to 10-monohydroxy metabolite, which does have anticonvulsant activity. It blocks the sodium channels and it hinders the spread of abnormal brain discharge. It also may modulate calcium channels. Looking at its clinical uses, it is used for partial seizures in adults and children. The side effects include nausea and vomiting, headache, and visual disturbances. It does have a safety profile that's a little better than carbamazepine, as it has less drug interaction due to its simpler metabolism. The next medication we will address is called divalproex, or also goes by the name of Depakote. The action of this medication is that it reduces the valproate in the GI tract, and it has many actions which include sodium channel blockade, blockade of the GABA transaminase, and action at T-type calcium channels. When we look at the clinical uses, it is used for partial and primarily generalized seizures. It does have side effects, which include hepatotoxicity and teratogenicity for women who may be pregnant. And these teratogenic effects include neural tube defects. So this is, again, a medication that is strongly recommended to be stopped during pregnancy, and that's the contraindication to its use is if the patient is pregnant. The next medication we will address in our armamentarium to treat seizures, lamotrigine or Lamictal. This is one of the newer medications, and its actions include the blocking of sodium channels, and it also blocks high voltage dependent calcium channels. Clinical uses include partial seizures, generalized seizures, absence seizures, and also the Lennox-Gastaut syndrome. It does have side effects, and one of the ones is the life-threatening Stevens-Johnson syndrome that, again, as mentioned before, starts as a rash and can progress to systemic problems with liver dysfunction. The contraindications to the use of lamotrigine include caution with drugs that utilize the UDP gluconyl transferase metabolism, such as phenytoin, because it can, again, change the drug levels of a medication. Also, there's caution urged with estrogen-containing oral contraceptives. The next medication we will look at is topiramate or Topamax. The action of this medication is that it blocks voltage-dependent sodium channels. It also increases the frequency of the chloride channel opening by binding to the GABA-A receptor. It reduces high-voltage calcium L-type currents, and it also has an action as a carbonic anhydrase inhibitor with possible action at the glutamate NMDA sites, which again would allow it to be inhibitory. When we look at the uses of topiramate, it is used for partial seizures. It is also used for primary generalized seizures. The side effect profile includes, number one, somnolence and paresthesias, weight loss, and even a risk of renal stones. The contraindications to the use of this medication are you must be cautious if you're going to use topiramate in a patient who is, again, on estrogen-containing oral contraceptives. The next medication in the armamentarium is ethosuximide or Zerontin. The action of this medication is somewhat in dispute, but we believe it probably inhibits T-type calcium channels to reduce the propagation of abnormal brain electrical activity. Its uses are pretty much limited to absence seizures. It is considered the medication of choice. The side effects include gastric pain, nausea, and vomiting. Looking at the next medication, it's pregabalin. It also goes by the name of Lyrica. The action of pregabalin is that it binds to voltage-gated calcium channels in the CNS, and it inhibits excitatory neurotransmitter release. The clinical uses are for partial onset seizures. It does have side effects of drowsiness, blurred vision, weight gain, and peripheral edema. The metabolism involves renal excretion primarily, so it does not induce the cytochrome P450 system, and is good in case the patient is on medications that already are inducing that system. Turning to the next medication, it's gabapentin. It also goes by the name of Neurontin. The action of this medication, again, is not known in terms of a precise mechanism. Its uses clinically, it is used as adjunct therapy for partial seizures, and it's also used for tonic-clonic seizures. The side effect profile includes somnolence, dizziness, ataxia, headache, and tremor. Again, it is primarily renally excreted, so again, it does not work through the cytochrome P450 system, and would be a good medication if a patient is on medications that are already working or being metabolized through that system. The next medication to look at is levetiracetam. It also is called Keppra. The action of this medication, again, is in dispute. Its uses clinically are for adjunct therapy for partial seizures. It also is used for myoclonic seizures. It is used for primary generalized seizures in adults and children. In its side effect profile, it includes dizziness, sleep disturbances, headache, and weakness. Again, this is a medication that is renally excreted. It does not work through the cytochrome P450 or the UGT metabolism systems. Turning to an older medication, we look at phenobarbital. It also is called luminol. The action of phenobarbital, it enhances the inhibitory effects of GABA-mediated neurons. Its uses include status epilepticus and chronic therapy in patients who are refractory to all other medications. It is not primarily used frontline for status epilepticus, but would again be an option if the patient had some sort of allergic reaction to phenytoin. Looking at the side effect profile, it includes sedation, cognitive impairment, and possible osteoporosis. The contraindications or cautions with the use of phenobarbital are that it is an inducer of the cytochrome P450 enzymes, and again, it can be very sedating and cause patients problems with that. In looking at the medication primidone, its actions, it has two active metabolites with a longer half-life than the parent drug. The first metabolite is phenobarbital, and the next one is phenylethyl-malonamide. Both of those have anti-epileptic activity. The clinical uses for primidone are for patients with refractory partial and patients with generalized tonic-clonic epilepsy. As we look at the side effect profile, as one could predict, it does cause some drowsiness due to its breakdown into phenobarbital. And this is a medication, again, that's not used very often. Turning to the next medication, it's tiagabine or tiagabine, which is gabatrol. The action of this medication is it blocks GABA uptake into presynaptic neurons. It allows enhanced inhibitory activity because of more GABA that is bound to the receptors. Its uses clinically include partial epilepsy, and on its side effect profile, we see tiredness, dizziness, and GI upset. Again, this is a medication that is metabolized by the cytochrome P450 system, and so causes some concerns for changing drug levels that work through that system also. The next medication we will look at is vigabatrin or Sabril. As we look at the actions of vigabatrin, it is an irreversible inhibitor of GABA aminotransferase, or the GABA-T. This prevents GABA breakdown, and it allows more GABA to be in the area of the receptor. This may also inhibit the vesicular GABA transporter. And what it causes is a sustained increase in GABA in the brain with tonic inhibition of electrical firing. Its clinical uses include refractory partial seizures and West syndrome. The side effect profile includes drowsiness, dizziness, and weight gain. The contraindications to the use of vigabatrin are in a patient who has a history of mental illness, as there has been a history of psychosis or an incidence of psychosis in patients who've used vigabatrin. The next medication we will look at is zonisamide or Zonegran, again one of the newer antiepileptics. Its actions include the blockage of voltage-gated sodium and T-type calcium channels. It also has carbonic anhydrase activity. Its uses clinically include partial epilepsy. As we look at the side effect profile, it includes kidney stones and also increased body temperature and also decreased sweating. The contraindications to the use of zonisamide would be in a patient who has a sulfonamide allergy, as this medication does have some sulfur base, and also cautious use in drugs that are metabolized by the cytochrome P450 system. The next medication we will look at is called felbamate or felbutol. The proposed actions for felbamate are that it blocks voltage-dependent sodium channels. It also competes at the NMDA glutamate receptor. It blocks calcium channels, and it potentiates GABA actions. Its uses clinically are for refractory epilepsies, especially the Lennox-Gastaut epilepsy syndrome. We look at the side effect profile for felbamate. It is fairly serious because felbamate can cause an aplastic anemia, and it also can cause liver failure. The contraindications to the use of felbamate are that it inhibits drugs that are metabolized by the cytochrome P450, and it also inhibits drugs that are undergoing beta oxidation as part of their metabolism. So caution must be used in that setting. The next medication to assess in our treatment for seizures is lacosamide or Vimpat, V-I-M-P-A-T. The actions of this medication are that it enhances the slow inactivation of voltage-gated sodium channels, and it also binds to the CRMP2 receptor to block neurotropic factor effects. Its uses are as an adjunctive treatment for partial seizures in those patients that are older than age 16. On its side effect profile, we see dizziness, headache, nausea, and diplopia. The medication does not induce or inhibit the cytochrome P450 enzymes, and so it's good in the setting of a patient having any problems with other medications working through that system. When we look at epilepsy syndromes, there are 3 syndromes that can cause significant epileptic activity. The first of these is the benign Rolandic epilepsy. The treatment options for that include gabapentin or lamotrigine. There's the infantile spasm syndrome or West syndrome, which is treated with corticotropin or ACTH and vigabatrin. And then there's the Lennox-Gastaut syndrome, which is treated with divalproex and lamotrigine. As we look at the anti-epileptic medications, there are some side effects that are common to most seizure medications. These are diplopia, sedation, ataxia, and dizziness. Some of these are dose dependent, and some of these may resolve as the patient continues on the medication. As we look at the non-medical options, there's the option of a vagal nerve stimulator. This is a surgical implant of a small pulse generator. It has a battery and lead wires that are wrapped around the left vagus nerve. This allows electrical impulses to stimulate the vagus nerve and to prevent abnormal brain electrical activity. The vagal nerve stimulator was approved in 1997 for medically refractory partial seizures, and this may allow medications to be reduced in those patients who get benefit from the vagal nerve stimulator. We'll turn now to the special situation of epilepsy in pregnancy. A woman who is pregnant and has a history of epilepsy should be on high doses of folic acid. There are certain medications that need to be avoided or weaned off before the patient becomes pregnant. These medications would include divalproex, barbiturates, and phenytoin. And generally, our therapy is guided in a pregnant patient with using the lowest dose of anti-seizure medications that are needed to control the seizures for long-term maintenance during the pregnancy. During the pregnancy, seizure prevention is important. The seizures are very detrimental to the fetus and to the fetus's oxygenation, and so seizure prevention will warrant medication changes or adjustments to protect the fetus.
I don't know why I'm bothering today, but let's try this. Which anticonvulsants are associated with blood dyscrasias? Carbamazepine and ethosuximide. Look, you chose this profession. Maybe put a tiny bit of effort into learning something. Stop wasting my time!
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide. Now it's time for your second quick review. Let's get started. What medications are metabolized by zero-order kinetics? Well, we talked about one in this lecture, phenytoin, but two others that you should be aware of are ethanol and aspirin. Next, list 7 drugs that are induced by the cytochrome P450 enzyme. So if it's an inducer, that means that other medications that are metabolized by cytochrome P450 will be metabolized at a greater rate, so they'll become less effective. So your memory tool is BCG PQRS. So the first one, barbiturates. The next one, carbamazepine. Next, griseofulvin. The next one, phenytoin, which we talked about in this lecture as well. Quinidine, rifampin, and St. John's wort. Next, what are the important considerations in epilepsy treatment with pregnancy? So the first one is folic acid supplementation, but that's true of any pregnancy, so you always want to have your folic acid in there. You want to avoid divalproex, phenytoin, and barbiturates. These are teratogenic. You definitely don't want to use these in pregnancy. And then when you do have to use other medications to help control epilepsy, you want to use the lowest dose to provide control. Now we try not to use these medications, but always need to remember you have to have a healthy mom to have a healthy baby, so you have to prevent those seizures. Next, in utero, phenytoin can inhibit the hepatic synthesis of what? That's going to be your vitamin K dependent clotting factors. What drugs are known for causing Stevens-Johnson syndrome? This is a life-threatening skin condition, can be really rapid and really impressive. So it really falls into 3 major categories and then 1 outlier. So the first one, seizure drugs. So most of the drugs that we talked about today, seizure drugs. Next one, sulfonamides. You want to remember that. That's a class of antibiotics. And then the penicillins. The one outlier is allopurinol. But if you can remember seizure drugs, sulfonamides, and cillins, as in penicillins, that'll get you most of your drugs for Stevens-Johnson syndrome. What are the adverse effects of phenobarbital? So we mentioned this during the lecture, but we need to talk about it a little bit more. Phenobarbital is very, very toxic. It can cause a lot of problems. It has a very narrow therapeutic window. So you need to worry about CNS depression. You can really get some altered mental status if you take too much of your phenobarbital. Respiratory depression, this is the one you really need to remember the most. People die from phenobarbital overdose. It doesn't take too many extra dosages of your phenobarbital to really start depressing that respiratory drive. It's also cytochrome P450 inducer. Remember, it's one of the barbiturates. It's contraindicated in patients with porphyria because it actually increases porphyrin synthesis. There is problems with physical dependence. So you take phenobarbital long enough, once you stop it, you'll have withdrawal symptoms. So you can have anxiety, tremors, weakness, nausea, and vomiting. It can potentiate seizures, even though it's an anti-seizure medication. And it can even lead, though rarely, to cardiac arrest. And then finally here, overdose. So the things that we talked about, CNS depression, respiratory depression, there's this narrow therapeutic window, so you got to be really careful that you keep a tight leash on the patients who are taking these phenobarbital. And often, we're not using these meds anymore. We've got a lot of other meds that we use for seizures and for sedation. Next, name the major mechanisms of action of the anti-seizure drug. So all these seizure drugs work in different ways. Some of them have multiple actions, but what are the major ones? So the first one are the GABA agonists. So think of your benzodiazepines and your phenobarbital. They're acting on the GABA receptors. They're increasing the chloride channel opening or frequency of opening to help decrease neuronal firing. GABA transaminase inhibition. So the transaminase actually breaks down your GABA. So when you inhibit that, you have more GABA activity. So ultimately, it acts as an inhibitor. Sodium channel blockade. A lot of the medications work on closing down those sodium channels. Calcium channels can also be blocked. Things like ethosuximide work primarily through that mechanism. And then a couple of medications, you actually get NMDA glutamate receptor blockade as well. All right, and that's going to end your second quick review. Now's a good time to pause the video and complete the in-session quiz. Then restart the video and we'll go through the quiz together. All right, it's time for your end-of-session quiz for your anti-epileptic drug lecture. Let's get started. Name the first line treatments for the following seizure conditions: absence seizures, divalproex, lamotrigine, and ethosuximide. Tonic-clonic seizures. Again, think of lamotrigine, but you're also going to add on levetiracetam and topiramate. Status epilepticus. You're going to think of diazepam, lorazepam, but you can also use fosphenytoin. Complex partial seizures. Lamotrigine, levetiracetam, and topiramate. Next, match the type of seizure to its description. Brief, abrupt, self-limiting, loss of consciousness, staring, spike and wave discharge on EEG. Think of absence seizures. Short episodes of muscle contractions, short jerks of limbs that occur after awakening. Think of simple partial. Abnormal electrical activity in a discrete brain region, abnormal activity of one limb or muscle group, sensory distortion, normal consciousness. Myoclonic. 2 or more seizures without recovery of consciousness between each one. Status epilepticus. Sensory hallucinations, mental distortion, altered consciousness. Complex partial. Young children, short period convulsions associated with infectious illness. That's going to be your febrile seizure. Loss of consciousness, continuous contraction alternating with rapid contraction relaxation sessions, and then post-ictal period, and that's going to be your tonic-clonic seizure. Next, match the following clinical descriptions with the most appropriate therapeutic agent. And your choices are vigabatrin, fosphenytoin, gabapentin, and levetiracetam. So a 22-year-old woman in status epilepticus, you're going to use fosphenytoin. A 9-year-old boy with benign Rolandic epilepsy, think of gabapentin. 32-year-old woman with tonic-clonic seizures, think of levetiracetam. And a 3-month-old boy with West's syndrome, you're going to think of vigabatrin. Which seizure medication matches the following description? Gingival hyperplasia. You want to think of phenytoin. Drug of choice for absence seizures, ethosuximide. Second choice for absence seizures, think of lamotrigine, divalproex, or valproate. Drug of choice for trigeminal neuralgia, and that's carbamazepine. All right, next, name some contraindications and major side effects of each of the following. First one is carbamazepine. You have to be worried about increasing the frequency of absence seizures. You have to be careful in your older patients, and then concurrent use with other drugs that utilize cytochrome P450. Major side effect also is hyponatremia. Divalproex, You don't want to use this in pregnancy. Side effects include hepatotoxicity and teratogenicity. Lamotrigine, contraindicated with drugs that use a UDP glucuronal transferase, and then you also want to be cautious with estrogen-containing oral contraceptive pills. Side effects, Stevens-Johnson syndrome, remember that, that's the severe rash that can be life-threatening. Phenytoin, contraindications, you got to worry about cytochrome P450 again, and also the UGT enzyme system, as well as old age. Side effects include nystagmus, ataxia, gingival hyperplasia, that's a big one, and neuropathies. Topiramate, be careful with your estrogen-containing OCPs. They'll become less effective. Side effects include somnolence, weight loss, paresthesias, and renal stones. Moving on. Name the drug most appropriate for long-term management of absence epilepsy. We've asked this a couple times. Remember, ethosuximide. All right, next, match the agents below with the mechanism of action. So the first one is carbamazepine. That's primarily a sodium channel blocker. Gabapentin is an unknown mechanism. Lamotrigine has multiple mechanisms of action. Tiagabine is primarily a GABA receptor agonist. Phosphonetoin blocks sodium channels. Divalproex has multiple mechanisms of action. Ethosuximide blocks calcium channels. Primidone is a GABA receptor agonist, and then topiramate also has multiple mechanisms of action. Moving along. 10-year-old child spaces out in class, stops talking mid-sentence, and then continues as if nothing had happened. During the spells, there is a slight quivering of lips. What is the diagnosis? This is your absence seizures. And what medication do we use for absence seizures? As first line, ethosuximide. Moving on. Which pharmacokinetic drug elimination principle describes the elimination of phenytoin at daily dosages below or approaching saturation of hepatic enzymes? How does this change as the dosage surpasses the therapeutic range? All right, so at dosages below or within the therapeutic range, phenytoin shows first-order elimination. So this is a constant fraction of drug that is eliminated with each passing half-life. Above the therapeutic range, you get zero-order kinetics, and this is a constant amount of drug that's eliminated per unit time. And this elimination then is subsequently slower. So it's the difference between a percentage or fraction of the drug that's eliminated and a constant amount of drug that's eliminated. All right, name the agent that is an irreversible GABA aminotransferase inhibitor that is useful in partial seizures. That's going to be your vigabatrin. And that's going to end your in-session quiz for your anti-seizure lecture. Thank you.